I'm going to talk today about the second part of what happens when it all goes wrong in bone, and that's cancer. So there are a number of tumours that can develop in the skeleton or metastasize to the skeleton. That's when cancer cells can spread throughout the body and take up secondary sites in other places around the body. That's called metastasis. And there's a number of cancers that can do that, particularly multiple myeloma, breast and prostate cancer. Now, prostate cancer I'm going to focus on for the majority of this talk because that's one of the areas that I'm quite interested in and one of the areas of research that we have here at the Bone Biology Division. Prostate cancer is one of the most common cancers in Australian men. It's the second most common cause of cancer-related death in Australian men. And a number of patients will develop metastases. That's when those cells can spread to secondary sites. And that's most frequently to the bone. Unfortunately, there is no cure at the moment for metastatic prostate cancer, so it's really vitally important that we look into this devastating disease and we try to find treatments and understand this in better detail. Now, people often think of cancer and metastases as a modern-day problem, but in fact, that's not really true. And I'm going to show you just two examples of that. One of a Scythian king who died around about 2,700 years ago, and another of an Egyptian mummy, so not new, not yesterday. And in both of these cases, what they found was when they used modern imaging techniques like MRIs or CTs that you might find in the hospital or even here in the labs, they were able to see changes within the bone that were similar to changes that we see currently in patients with metastatic prostate cancer. And they were able to then hypothesize that those changes were probably as a result of these individuals having prostate cancer and it metastasizing or spreading to the bone and causing those changes in bone. But it really wasn't until about 1889 that this gentleman here, Stephen Paget, who's an English physician, really identified the link between prostate cancer and cancer, in general, that can spread to specific sites within the bone. And he was really interested in breast cancer, and what he said was that in cancers of the breast, the bones suffer in a special way. And I think that's a really nice statement, but what he was trying to say from that was really that cancer cells often, in patients with breast cancer, often had secondary growths that were present within the bone that couldn't have occurred purely by chance or purely by coincidence. And now we really know that there are a lot of those cancers that can go to the bone, including breast and prostate and multiple myeloma. And what Stephen Paget compared those cancers was to a seed that could only grow when they fell in congenial soil, which was the bone. And he said it's really vitally important that we understand the properties of those seeds, but it's also really important that we understand the soil that those cancer cells fall in, and that's the bone, and that's the skeleton. I'm going to spend a few moments just talking through how our understanding of how those tumour cells can arrive in bone and how they start to grow in bone. Michelle has already presented this, as you would have seen this diagram earlier on, and it really speaks to this idea that bone is a very dynamic organ, and Paul's talked about that as well, and the interactions of different organs with bone. And it's full of different cells that have very different roles and very different properties and very specific functions within bone. And I've just taken a magnified view in here in the internal surfaces of bone, as you can see the surface along here and all those different cells. But if I just strip that back for a second and just look at a few of the vital components, number one, the blood vessels that can flow into bone, and some of those cells that can line the bone surface, including osteoblasts and osteoclasts that both Michelle and Paul have talked about earlier on today. And so cancer cells, having left the primary site, and that's at the prostate, can flow through these blood vessels and arrive at sites within bone. And some of them can just pass right through the bone, they can continue on passing around the body, but some of them can move out of those blood vessels and can move along to sites along the bone, as you can see here. And they can remain in that state for an extended period of time, many months or even years, evading radiotherapy and chemotherapies and different treatments designed to target the cancer cells. And they could stay there in a sleeping or a dormant state for many years and many months. And Peter's going to talk about some of that in his next talk after me. But eventually something will happen within the bone, and those cells will wake up and they'll start to grow. And you'll get this large tumour forming. So that's when those cells start to divide and they start to grow to form this large tumour. And in that scenario, those large tumours that are growing in bone can have effects on the bone as well. causing aberrant bone formation, that's increased bone formation. But once those tumours are established in bone, it's very difficult to treat and it's very difficult to cure. And then again, following a period of treatment, some of those tumours can actually come back and can recur. There are a number of treatments that we can use that are bone-targeted agents that can directly target the bone and some of the effects that the tumour cells can have on bone, and that's bisphosphonates, and I'm going to let Angela talk about some of that later on today. But really what's critically important is that we understand the early events in the disease, because we know that as those tumours start to grow into these large tumours in bone, that they're very difficult to treat. So we really want to look at the very early events in the development of this disease and understand the colonisation of those cells within the skeleton, because that'll let us understand those cells and also to help us develop some new treatments for bone metastatic cancer. Until now, actually being able to identify those cells and to look for those cells in bone has been very difficult, just because they're very rare, these cells, and because they're very difficult to find. But now, in a number of different models of prostate cancer, we're actually able to identify these cells. And I'll just walk you through this slide because it's quite detailed. So we have, and you might have seen Michelle present some of this similar kind of images earlier. So what we have in blue is the internal bone surface, and what you can see in red are those cancer cells that we've dyed a red colour, and those are the initiating cells. So those are the cells that colonise the bone. And in green, you can see the tumour colonies. So that's lots of those cancer cells as they started to grow and as they started to divide and form these large tumour colonies in bone. So what we're able to do now is we're able to find those early seeding events, those colonising cells within bone, these cells here and here, before they start to form these large tumour colonies. And what we can do is we can better understand these cells to inform treatments. And really that's what we're starting to do now as part of the PROMISE programme and this prostate cancer metastases. And that was a programme that was spearheaded here by Professor Croucher to really look at understanding prostate cancer bone metastases, how it starts, how you have this extended period of dormancy where those cells can sleep in bone, and then what actually wakes them up. And we've taken a number of people, both based here at the Garvan Institute, across Australia and worldwide, to really come together to tackle this problem of prostate cancer metastases. And that couldn't really be done without some of the funding that's provided by the public to really help us to tackle these big questions and to tackle the real problem of prostate cancer metastases. And with that, I'll finish up and I'll pass you on to Peter.